I want to welcome everyone to the fourth installment of our Summer Roundtable Series. This year, our program is called ASTARISQ, or Addressing Systemic and Structural Racism to Improve Safety, Quality, and Trustworthiness in Health Delivery Systems. Today is all about addressing equity in healthcare access and affordability. It's my pleasure to introduce our moderator, Marie Asad, who is a patients professor, class of 2022, and the manager of community outreach and engagement at Blue Cross Blue Shield of Illinois. Marie, take it away.
Awesome. Good afternoon. It's a beautiful day here in Chicago. Thank you, Hillary. So again, I'm Marie Asad, and I am a proud patient professor and manager of community outreach and engagement at Blue Cross Blue Shield of Illinois. I'd like to go ahead and introduce our esteemed panelists. I'll start with Eva.
I had to unmute. Hi, my name is Eva Stahl, and I am the Vice President of Public Policy at RIP Medical Debt. RIP Medical Debt is a national nonprofit organization where we leverage donated funds to purchase and abolish medical debt for individuals across the country. So it's really exciting work. It's timely. We understand that it's just sort of a small fix. It's not a long-term solution. So my job as a part of the policy work here is to think upstream about how to mitigate the harm of medical debt, which is a tremendous problem for our country and disproportionately affects people of color.
Thank you, Eva. Welcome. Elita.
Hi, I'm Elita Hill. I'm a Black woman with cornrowed gray and black hair. I'm wearing a pink or lavender top and I have a blue background. I consider myself an anti-racism advocate who serves throughout the Charlotte, North Carolina region. During the 2020 COVID lockdown, I organized an RIP medical debt campaign along with fellow anti-racist advocates here in the Charlotte area. And we had decided to bring debt relief to North Carolina counties with majority minority populations. We had identified counties that were predominantly Black, brown, and people of color, which in the state of North Carolina turned out to only be 7 out of the 100 North Carolina counties. So we had to expand our effort to include other counties, and we had decided to particularly focus in on counties that had majority Indigenous Native American populations. And so our campaign expanded into New Mexico and Arizona. And during the lockdown from Labor Day through Kuumba, which is the 6th day of Kwanzaa or New Year's Eve, we actually abolished over $2 million in medical debt for over 1,000 people. In my professional life many years ago, I left my beloved career in public health research. I just could no longer live with being in the role of playing Lady Macbeth by participating in decisions that harm Pascua Yaqui, Navajo, and Hopi peoples. There were decisions that were made on a regular basis that diverted monies, important money that should have been dedicated to improving their health and well-being, but in public health, you try to get more bang for your buck. And so monies were continuously diverted into larger populated counties like Maricopa County. But anyway, and so I just could no longer deal with that. But I was privileged and am privileged to have a secondary high demand skill as an ASL interpreter, which is my current career, a career which has given me the gift of coming alongside both deaf and limited English proficient peoples as they navigate and access systems of care through our health systems and well-being. And I'm a patient's professor.
All right. Well, thank you, Elita. That's quite the introduction there. Jared, can you introduce yourself for us?
Yeah, thanks so much for having me. My name is Jared Walker. I am the founder of $4. $4 is a nonprofit organization that helps eliminate medical debt by enforcing hospitals' charity care policies. So started the organization after watching my own family go through a medical crisis and realizing when you have a medical emergency, a lot of times you have a financial emergency at the same time. And I wanted to help people through that. So a lot of my comments and feedback will all be through the lens of hospital charity care. That would be my area of expertise. So thank you so much.
Thank you, Jared. And Joe, last but not least.
Hi there, my name is Joe Huang. I'm a family physician currently serving as medical director for population health with Multicare Health System and Physicians of Southwest Washington. Multicare is the largest nonprofit, not religious affiliated health system in the Pacific Northwest. I bring experience as a physician, mostly in the community health space, and I've also worked in rural hospital administration, large health system, medical group leadership, and in my pop health capacity, certainly have taken on much more of an insurance lens as well.
Awesome. Thank you. We'll go ahead and get started because we want to make sure we get to the good questions that we have today. So we'll go ahead and get started with number one. One major barrier to addressing equity in healthcare access and affordability is awareness. What are the inequities and obstacles to access to healthcare and health insurance in the U.S.? And I see Elita thinking, who wants to tackle that one first?
I can just jump in and get us
Sure.
started so Elita can keep thinking. So I would say that, a huge barrier and something that we see in our work, right, is that we know that medical debt disproportionately hits households, particularly people living in lower income households, Black and brown households, and disproportionately Black households in the South. And I think it's really important to understand that, Medicaid is an important protective factor in protecting people from medical debt. And so part of the reason that we see that that dissonance and that gap is because people don't have access to insurance and therefore end up with unpaid medical bills, or they delay their care, or avoid care because of fear of medical debt. So certainly I would say that there needs to be increased awareness and visibility around the fact that that is a really simple solution that has not been picked up by a number of states that could help mitigate the harm and inequity of medical debt as far as we see it.
Thank you, Eva. Really good points there. Jared, looks like you may have come off mute.
Yeah, I mean, I'll kind of tackle this, I guess, through the lens of charity care. I mean, our mission is to hopefully make charity care known, easy, and fair. One of the biggest obstacles is telling people about it. Most people have no idea that most hospitals in America are nonprofit organizations, and they have to offer free or reduced care for people that meet the income requirements. And they're a lot more generous than people think. So we have millions and millions of people declaring bankruptcy, going on payment plans, taking out loans for medical bills that they actually don't have to pay. So I think one of the big problems is trying to tell people that there is this program and convincing them that it's real and it's not too good to be true. Like a lot of people, we spend a lot of time trying to convince people that it's a real thing that can help. So it's definitely one of, we always call it the best kept secret of the Affordable Care Act. And I think that it's, a huge obstacle of trying to get the word out about charity care.
Thank you, Jared. Thank you, Eva. Anyone else want to tackle that one? Joe? I see Joe and then Elita. Go ahead, Joe.
Sure. I think one of the biggest things to call out is that, the way that the health system is set up is structured to enforce existing patterns and structures of inequity that exist more broadly in society. And so, access to the best insurances, and commercial insurance is really contingent on having, the sort of job from the sort of organization that's going to provide that for you. And so, so again, the way that perpetuates inequities is, I think, pretty apparent. And then the way that health systems will prioritize patients with quote unquote good insurance and how that impacts folks that are underinsured or uninsured is pretty significant, right? There's always, fallback protections for folks that don't have the best insurance But those insurances are always going to be deprioritized from an access perspective and can lead to delays in care and differential care. And I think additionally, because of the shortages that we see, particularly with primary care, I think that's where really, I think the domino effect is most prominent because there is just not enough primary care access for the community at large and for the population at large. Spots with a primary care provider that can really coordinate your care and help, provide a plan for how to best navigate the system is, again, I think, differentially tilted to those who have the best insurance.
Thank you, Joe. That definitely resonates with me when you talk about the shortage of primary care physicians, even in a large city. That could be an issue. And I know it's even more so in our rural communities. Elita, please go ahead. Chime in on question 1.
Sure. Well, as an interpreter, the lens that I come from is language. Language is a huge barrier to access. Individuals for whom English is not their first language, or individuals who are deaf and hard of hearing, have to rely on communicating with their healthcare providers through interpreters, which are oftentimes in short supply, and or healthcare systems are just not willing to pay. And the institution of interpreting services that are provided through either telehealth or through virtual means may not necessarily maximize and meet the communication needs of individuals. And with that, difference in language as a barrier, there's also a cultural component as well. So the way individuals think about their relationship to healthcare providers, their relationship and how they are to interact with healthcare systems is oftentimes very different than how the American healthcare system is structured. And so the idea of, going in to see a provider and how do you negotiate through the system in order to maximize or even access care is very confusing, is very convoluted, and there are not a whole lot of people to help individuals who are limited in English or even deaf people to navigate through those systems. So those are huge barriers.
Yes, thank you for your perspectives. I think that was really good. And piggybacking on that question, how do these barriers exacerbate or amplify affordability issues? And Elita, I know since you've just kind of chimed in, I'll give you an opportunity if you want to talk about how the language barriers impact affordability issues.
Right. So I think Joe highlighted this, and I'll overlap with what Joe mentioned. Because our healthcare system is so dependent on the level of insurance that you have based on employment, folks in the disability community or deaf and hard of hearing people or folks who have limited English proficiency or who are non-English speakers oftentimes are in very low paying jobs and or in jobs that are part-time or don't offer great insurance, or who have insurance but the deductibles are really high. And so that's going to really dictate where they get access, what kind of treatment they get, and also have questions about, so if I have this limited amount, I have to pay for a prescription and I have limited income. So am I going to eat? Or am I going to pay for my medication? Or am I going to ration my medications? Or am I going to choose to not follow up on each of those, recurring appointments and space them out? And that's just compromising their overall health. And the stress of having to make those kinds of decisions also exacerbate health conditions.
Yeah, thank you. Thank you, Elita. Joe, it looks like you are mute. You want to go ahead?
I'm sorry.
No, you're fine.
What you're saying, Elita, really resonates with my experience as a provider in a community health setting as well. Having dealt with, the majority of my patient load being non-English speaking for most of my direct clinical career. Yeah, that really speaks to me, and just the heartbreaking examples of how that impacts patients and how and the decisions that they make about their health, right? And I think adding on an additional layer, you think about folks who may not be documented, and the fear, particularly in today's environment, for what that means. There's so many misconceptions about, gosh, if you go to the hospital, what is this going to mean for potential risk to you as an undocumented individual? And again, the decisions that causes, again, just people want to do the right thing to take care of themselves and take care of their families. I remember a woman who saw me postpartum after having her baby. And so she just had a baby about a week ago. And I was wondering why she was late. It turned out she was about a half an hour late because she had to walk over 10 miles with her baby in a baby carrier because she couldn't figure out how to get transportation, but she knew how to get to the office. So she just decided to walk because she knew it was important to take care of her baby. And so when you get to the granular individual level, I think you see kind of the impact that has on the decisions people have to make and the sacrifices or trade-offs that people have to make to try to get care for themselves and their family.
Yeah,
I think that's so right, Joe. And like the systems don't match up with the problems, right? I talked to a physician last week that was interested in medical debt, and he was sharing a similar story about a patient that sort of disappeared on him and missed several appointments. And it was because her Medicaid, she got pulled from Medicaid and she couldn't figure out how to get back on. So she couldn't take her medication and she had a chronic illness. So she missed her medication, she missed her appointments, and she didn't reach out for help. And the provider didn't really know how to help her because he wasn't connected to the right supports and systems, even internally in the hospital system, to say, how do we get this person re-enrolled in Medicaid? So there's a lot of siloing that happens within these systems that sort of set up a wall between what people need and their reality is, and what the system is actually providing and how it's designed. These systems are not designed in community need or community voices in terms of what those needs are. And so those ripple effects are very real, particularly in terms of affordability. And just one more example that you lifted up, Elita, that I actually had a conversation about this week is we're starting to see a lot of stories about people who are on disability and also have medical debt. And you're like, wait a minute, how is that possible? And it's possible because there are such delays in the system that people are racking up medical debt while they're waiting in these long lines for disability. And there's no communication. There's such siloing between these systems that people are getting caught. And then you add the layer of people not being able to access Medicaid in states that don't have Medicaid that maybe could be a stopgap for them in the interim, but they don't have that either. So it's a real roadblock between the system and the reality.
Yeah, Eva, thank you so much. You bring up a really good point. That's one of my responsibilities now. We're focused on Medicaid redetermination here in Illinois, and I know across the country, a number, thousands are losing their Medicaid every day now that the public health emergency has ended, and those it's really becoming a situation that a lot of states are going to be struggling with in the coming months. Anyone else want to chime in on that question before we move on to the next one regarding affordability? Jared, did you have anything to add?
I was trying to figure out which angle I want to take. I think one, we see so many people just avoid and neglect care because of fear that they can't afford it. So that is a huge thing that it impacts affordability because people wait and then it gets worse and then it's more expensive and we see that all the time. The barriers when it comes to hospital charity care, I think we see a lot of times where hospitals will add things into their policies where you don't get charity care if you don't live within these zip codes. You don't get charity care if you, so it's like they have a residency or a minimum bill requirements, insurance, or a whole bunch of other things that just take people out of getting charity care, which shouldn't be happening. So those are a couple little things, but yeah, I feel like everybody covered that. Great.
Yeah. Great, thank you so much. We're going to move on to the next question. What are examples of how you have addressed affordability issues for the populations and communities you serve? So some great examples I think have already been shared, but I want to know if there's anything that hasn't been mentioned that you're already working on or that you'd like to share with this group. Addressing affordability issues. Elita, I see your eyes.
Yeah. I can't control them. I thought my glasses would hide them over. No,
No, you're fine. Please,
yeah.
please be fine.
So, as an interpreter, there are limits to, for me personally. So in my capacity as an interpreter, ethical limits that I experience, HIPAA limits. So, and in order to remain as neutral and objective as possible, that's kind of like that's an area that I don't particularly, while in my heart, I want to attack. There's some professional limits that go with that. But I did want to just speak to my experience in Bermuda for a second, which might seem like a sidebar, but not really. When I lived there, as an American living in Bermuda, it was eye-opening to me to live in a country where healthcare was paid for, end of story. And even people at the time that I lived there, there are visitors and tourists, and when they had accidents, for example, they could go to the emergency room and their bill is paid for. There was no cost to people who were even visiting. Folks who, Bermuda is a very, very small island, and there are physicians that are there, but there's not this great expanse of physicians with a large number of specialties just because of the number of people that live there. But if a person who's Bermudian was diagnosed, and I have plenty of friends who are diagnosed with illnesses and conditions that could not be addressed, they could choose any hospital in the United States, Canada, or England to go to, and their medical bill was completely paid for, including travel, the duration that they were there. In some cases, the companion who was with them was there. So for me to experience, and all of us as Americans were like, oh my gosh, like, how is this even possible? To experience a system that was humane and that had no austerity whatsoever, but just as the element, we just take care of people. That to me, it was just so eye-opening. Yeah.
Thank you. Thank you, Elita. Anyone else want to chime in? I know you've already probably shared some examples, but is there anything that hasn't been discussed so far as it relates to examples of how you've addressed affordability issues? Joe, I see you're thinking, is there anything you haven't already mentioned? That was quite a story that you shared regarding the mom that had to walk 10 miles after she just delivered a baby. Any examples of other ways to support as it relates to affordability?
Yeah, two examples from multi-care, one kind of at a smaller scale and one kind of more large scale. The smaller scale example to share is we worked with local community leaders and community organizations to develop an outreach program for breast cancer screening in the communities of color in the areas that we serve. And so we partner with the community organizations to provide more robust education in the community where folks were, and to really, again, not just educate, but to provide those additional mammography services and create that access for mammography for the patients that we outreach to via that program. On a larger scale, again, we recognize that it would be impossible for us to go out as a large health system and unilaterally target Medicaid populations and uninsured populations. And so we figured we could best serve our communities, including the underserved communities, by having more robust partnership with the largest community health center chain in Western Washington, which is CMAR. And so we've created a really robust partnership with them to be able to take really good care of their patients, to share accountability for providing access in primary care for patients who are underinsured or uninsured. We invested quite a bit in providing them access to Epic, which is, of course, one of the largest electronic health records in the country, and it's unfortunately not cheap. And so we helped their entire network implement that EHR, which also is the same health record that most large health systems in Washington have. And so they could be fully integrated with the other health systems in Washington and therefore provide better coordinated care for all of their patients and the patients that we have together with them.
All right, thank you. Did I miss any other examples? We can move on.
Yeah, I would just say, Joe, that's such a great example of, the small P sort of policy change that you can make internally, something that we often promote. And we actually work with Jared on part of the sort of referral issue too. I mean, I think Epic can be a great tool sort of for flagging people that need extra support, and that those systems need to be like woven into all of the social determinant work that's going on, where we're seeing a lot more health systems engage in social determinant screening. Like, how is that pathway connected to some of these tools and also some of these programs like financial assistance or financial counseling and support, or even Medicaid enrollment or ACA enrollment. So, I think for us, we abolish debt, right? And that debt can range anywhere from a couple $100s to $50,000 plus. And those can be moments of change for people in their individual lives. But often the population we serve, which is under 400% of poverty, these families are struggling with just the realities of wealth inequity. And so that they're burdened with so many other pressures and stressors in their lives. So we also recognize that we need to work in partnership with a lot of other folks to make sure that we're wrapping around these households in a more robust way. So part of how we do that is we've launched a program to start working with community partners and work with local communities and counties to think about how, when we provide debt abolishment, how do we pair that with upstream supports, much like you're talking about, Joe, making sure that community partners are engaged in a referral opportunity to make sure that we're giving support to others. And one of those referral partners is Jared. And so making sure that when we catch people early on who might be a candidate for financial assistance, that they can be connected to Jared's organization to get the support they need to get financial assistance.
Absolutely. Thank you. And a couple things that really resonated with me, and I think, Eva, you also kind of piggybacked on that, was the robust need for partnerships, the robust partnerships. Joe, that is really key. I know from my perspective, just working in Medicaid managed care here in Illinois, we really are relying on our partners. So here, currently, it's back to school time here in Chicago. And so we have a partnership, and we actually developed this right before the summer started, to partner with the Chicago Public Schools to provide Medicaid redetermination resources at each of their back to school bashes. But also, in addition to that, we thought it was important to provide some healthy food and access to care resources as well. And so for each of those events, we're hosting pop-up farmers markets to bring no-cost fruits and vegetables. So that's also a way to kind of help close the gap, but also welcome the families in and get the students excited about going back to school. So we'll move on to the next question, but I really definitely love the comment about robust partnerships, because none of us can do it alone. We don't live in silos, and we've definitely got to rely on one another to address the needs to bring equity to our communities. So the next question is, what are some of the calls to action to help bring everyone together to change practices and improve access to care? So the call to action, and what do we want to do to have everyone come together to change practices and improve access to care?
I'll quickly comment again through the lens of charity care. I think a big call to action, and I know even I've talked about this a whole bunch about hospitals adopting presumptive eligibility tools and having a standardized application for charity care, and making this process a little easier for patients. Because right now, all of the responsibility falls on the patient. The patient has to find the program. The patient has to dig through the website, find the policy, find the applications, and then 95% of the time, hospitals require you to fax or mail your applications in. And there's just a lot of barriers. So through the lens of charity care, there are a handful of call to actions, but I would say standardized application, presumptive eligibility, and just doing a better job of telling patients about the programs and making it easy to apply.
Thanks, Jared. Very good comments there. Anything else?
I would just say, and include the insured.
Include the insurer. I love it.
Insured people need financial assistance too. And often there's a focus on uninsured people as the only eligible recipients of financial assistance. So it's important to modify that, because we know underinsurance, as Joe has mentioned, is a really huge problem for people, particularly low-wage workers in our country, who are often saddled with medical debt and high unpaid medical bills because they have something called high deductible health plans, which should not be a thing. And those are very high deductibles and high out-of-cost payment requirements for people with income levels that could never even afford to utilize their insurance. So that's a huge barrier and call to action for people to speak up and speak out on that issue, and beyond the space of just the ACA marketplace plans, but employer-sponsored insurance.
Thank you, Eva. That's a really good point. I think that's a point that hasn't been made in the past about the importance of including those that are insured and the working poor in some instances. So thank you. Anyone else want to comment on that last question, Elita?
Sure. I think everybody, I would suggest that everyone become very familiar with and become very knowledgeable about lep.gov, which is language English proficiency.gov, and policies and laws that exist to ensure that there's language access. And there you'll find in many different regions or within organizations, it would be really, really helpful that you disseminate your information in languages that reflect your respective communities. So much of this information is presented in English, and for folks for whom English is not their first language, means you have all these great opportunities, you have all this great programming, and folks who don't speak English have no access to even know. And becoming familiar with, there's toolkits there, and becoming familiar with what's happening on the state level and within your county as well, that there are entities, programs that exist that would help in making those translations actually happen for documents, websites, getting your public service information out. I really think that is a very important focus.
Thank you so much, Joe. I know you have a comment on this topic. Can you provide some insight there as well?
Yeah, I mean, so certainly 100% echo what Elita said for folks with limited English proficiency. I did want to get back to a comment that Eva had started as well, and really amplify that, the high deductible plans, and it's not just high deductible plans. It is, I think, trends in insurance overall to shift more cost directly to patients, right? And, I think that part of this is a symptom of just how dysfunctional and unaffordable the health system writ large is, right? And so I don't think this is necessarily, although it may be in certain cases about employers maximizing their profits. Again, maybe in some cases, right? But I think even where employers legitimately in good faith want to do what they can to take care of their employees, it's becoming harder and harder for them to afford to do that, right? And so I think from a broader perspective, I think some of the call to action is thinking about what are the systematic drivers of uncontrolled inflation in the health system overall, right? And who are the winners? Who are the losers in that? We as a society, like any society, have limited resources, and how those resources are divided and prioritized, of course, is going to match existing structures of power and amplify inequities that exist in the system, right? And what do we need to do to mitigate those? How do we address the legitimate interests that everybody has to be able to improve the health of our population? But really, how do we identify where value is taken out of the system to the profit of the few? And really maximize value to the many, and particularly those who are always marginalized.
No, thank you, Joe. I appreciate that. Moving on to the next question, because I think we've got a number of questions. I think we've got over 100 attendees. I'm sure there's lots of questions for this distinguished panel. What's on the horizon for your work? What are the emerging trends, opportunities, or new challenges in your current work that will lend to this topic and help get us to the next level in addressing these issues of equity? I'm going to call on Eva on this one. Eva, did you have a
Well, I'm sitting here processing.
Oh, okay.
You can call on me. You can call on me. I think on the horizon for our work is, recognizing that we are just a stopgap for families and individuals by abolishing their debt. How are we robustly partnering with communities, with advocates, and with others to really think upstream? And how are we using our unique position as an entity that is engaging and working in partnership with hospitals and health systems to really sort of call them in and have more robust conversations about with them and other stakeholders about how to mitigate this harm. We're really stuck in what Joe referred to as a very dysfunctional system, healthcare system and healthcare financing system specifically, that are not holding patients harmless. And so more needs to be done, and everybody needs to pitch in to address some of these complex issues. There are a lot of complexities associated with the exchanges that happen between insurers and health systems and the medical billing process that largely live behind a curtain. And I think there need to, we sort of see ourselves as sort of a broker, since we participate in part of that process and debt abolishment and see pieces of that, that we can be a helpful partner to move this conversation upstream. So for us, that's what's on the horizon.
Thanks, Eva. Joe, did you have a comment on what you're working on? Any emerging opportunities?
Yeah,
What's on the horizon for your work?
There's so much going on, and I don't think it's all doom and gloom. I think that, for example, a lot of the work and the policy that CMS and CMMI have really had in place and continue to push, from the advent of the Affordable Care Act and through today, really is increasing the pressure on health systems to think about not just doing stuff to people, but how do we actually keep populations healthy, right? And lower the cost of care and make care more affordable to our communities writ large. And I think the pressures to integrate health equity into these innovative care models and payment models is really, really a powerful trend. And, for us as a large health system, coordinating as we get more and more, for example, we have so much more, again, because of programs such as CMS programs, we have really implemented a lot more robust collection of data, right, about race, ethnicity, language, SOGP, all the sorts of things that will even tell us what are the inequities that exist in the communities that we serve. And so we wouldn't have had that 5 years ago, 10 years ago. And so understanding what are the inequities in the communities that we serve in terms of actual health outcomes, how do we marry that with our efforts in the community as it relates to health equity? How does that relate to how our foundation participates with community agencies that are providing funds to the communities that we serve? We've never really had the sort of coordinated thinking around this that we do now. And so we've really kind of stood up a health equity and social determinants of health governance body for our system to be able to better navigate this. And I think that doing this in partnership, not just with community agencies, but as I think we've referenced before, talking about how we do this in partnership with, for example, the community health centers, how we do this with our payer partners. We've not just entered into risk for the total cost of care with Medicare, but with our largest commercial plan in the state as well. And they have a great interest in health equity as well. And so how do we align where we're seeing health inequities in our shared patients by using the new data that we have and the partnerships that we have to better mitigate these inequities?
Okay, thank you. Thank you, Joe. Jared or Elita, did you have a comment on emerging trends? What's on the horizon for you and your work?
Yeah, I can quickly add what is next for $4. We are trying to create more of these partnerships with organizations that can help or use the data that we have in the patient experience, patient stories that we have with charity care to try and make better laws, better policies, get hospitals to just either follow the policies that they currently have or make better policies. So that is what is next. We are eliminating medical debt for individuals, but now trying to take that and use that data and stories to drive policy change.
Just to kind of add in, and one of the emerging trends or challenges that we see on the horizon in the world of interpretation and translation is the efficient use of artificial intelligence for or the potential of use for artificial intelligence. And one part of inequity deals with the digital divide. So as we continue to move forward and collect data and shift to telemedicine or shift to converting translations and hopefully not substituting human beings to do the interpretation and translation, that is a huge challenge that's on the horizon. And my hope is that we would keep humans at the center and that human translations incorporate the emotional intelligences, cultural ways of knowing, and wisdom and ethical discernment. It adds to the patient outcomes. And it's just not merely information, text translation, or information that's translated through an artificially designed program. So that's one of the challenges that's on the horizon, especially as entities think about cost cutting.
Cost cutting. Oh gosh. Thank you, Elita. So thank you all for answering those questions. I want to go to the Q&A, and if you haven't had an opportunity to our attendees, if you haven't had an opportunity to submit your question, please go to the Q&A box to add one. We'll go ahead and start with questions. I did see one that asked, how effective is the use of integrative care? And it looks like we've already had we have a response there. We have not. Anyone want to tackle that one? How effective is integrative care? Joe, you look like
for clarification, there are a lot of notions that can be labeled integrative care, and so whoever submitted that question, if you could maybe expand.
Yeah. Okay. Yep. If you can come back and provide a little bit more clarity around what you're defining as integrative care, that might be helpful.
But I would just add in, and maybe Joe, you could speak to this, and I think you already have, but just sort of the broad idea that we're thinking outside of the physician's office in terms of how we support, how we support individuals and families, that can be incredibly important for mitigating the harm of medical debt or health issues that might come in connection with financial insecurity, that having access to some of those programs and support really matters.
Yeah. No, I think that's right. Thinking about how you navigate social determinants with community partners. And I think the community partner piece of this is key, right? We did actually roll out a really robust SDOH screening program and invested in a common platform with many other providers in the state to be able to actually submit kind of standard social determinants of health cases that would then be kind of distributed to community partners. And we quickly found that the community partners were vastly overwhelmed by the referrals from health systems, and to the extent that it became non-functional. And again, I think that this just shows to, again, right intent by everybody involved and significant investment made, but not having the structures in place, the processes in place yet to fully execute it. I think another angle on integrative care is how do we de-silo physical and mental health, right? Which again have had historically different ways of being funded, of being delivered, different rules even around privacy that make for all sorts of weirdness on, on the provider and patient end. And I do think that there is a great deal of benefit to really thinking about the whole person. Again, not just the whole person and their social needs, but the whole person with their physical and mental health. And how do we provide that those sorts of services in an aligned way, or even more ideally in the same location, so that we're providing for those needs with different professionals to the same patient at the same place.
No, that's a really good point. Thank you so much. So we have a question from our fearless leader, Dr. Mullins. And so he did not go anonymous, so I had to give him a shout out there. Can you also address the cost of non-medical aspects of care? So we're talking more, again, about social determinants of health, those that are both financial and just supportive, that impact health disparities that aren't about cost of drugs or doctor visits, but transportation, childcare, housing. I'll throw that in, Dr. Mullins. I know you didn't add it, but housing is certainly an issue. What are some of your, to our panelists, what are some of your thoughts around how to address those non-medical aspects of care?
So I'll just jump in because, you know, there's a lot of research that that shows that the investment of government dollars in social services lags way behind our investment in medical care and health systems. Yet we know that what is really driving a lot of inequities and poor health is connected and correlated to how people live. Do they have stable housing? Do they have enough to eat? Do they have a way to get around? Do they have a job that pays a living wage? So it's a long-standing problem in the country that is, you know, those decisions are made anywhere from the local to the federal level about how we value and invest those services and supports that are important preventative measures to keep people healthy and reduce healthcare costs. But that sort of lopsided investment structure has certainly not shifted.
I agree. Thank you, Eva. Anyone else want to chime in around social determinants of health? And I know Hillary's already put the definition there for us, for those that may not have been familiar with SDOH as the acronym, as those of us that live this every day use that acronym more often than probably we should for lay persons. Anyone else want to chime in as it relates to non-medical? We did touch on it quite a bit. Go ahead. I'm sorry, Joe.
I can, you know, again, I think folks have a sense of what this means, but I'll give another, I think, very specific example of the impact of social needs on healthcare expenditures and how we try to mitigate those at a small scale. I mean, we have a particular area in one of the cities that we serve that has a very high, a higher concentration of people experiencing healthlessness, and so and also an increased prevalence of substance use. And there are many individuals who are frequent visitors to our hospitals and in particular emergency rooms, which creates quite a bit of system expense that those individuals are not necessarily bearing themselves, but those costs are ultimately shifted to every other patient and shifted in other ways throughout the community. And so not having access to housing or effective substance use disorder treatment services can again accelerate and amplify in a way that increases costs for everybody in the system. And so on a relatively small scale, we invested in low-barrier housing, temporary housing for folks who were in those sorts of situations to be able to try to break at least temporarily a little bit of that cycle, get them into a house situation and manage some of the needs that they might have, whether it's an infection that is associated with an injection site or other things of that nature.
Thank you, Joe. Appreciate that. We've got a couple other questions here. How do you work with veterans? And I know we talked about a lot of different groups. Veterans is also a group that there are some disparities there in how they're receiving services, and in some cases, the quality. Who do you not, I'm sorry, the question was, how do we not have access to healthcare as a benefit for servicing our country? Okay, so in your work, how are you working with veterans? Are you seeing any disparity there? And what are your recommendations, or is there any emerging trends that you'd like to see as it relates to working or serving the veterans that have provided service to this country?
I can speak to that if others want to jump in front of me, but
yes, go ahead, Eva.
I'll go ahead. So, veterans unfortunately carry quite a bit of medical debt. So we end up running campaigns to support veterans. And it's also been acknowledged that this is a problem. So I think what the person is responding to is that, your veteran health coverage often needs to be linked to your service in order for that coverage to pay for the services, the health services that you're getting for your illness or your visit. And that can be really challenging, as everyone can probably imagine, to be able to draw that line. It's a longstanding problem for veterans across the country. And so many of them also end up with medical debt, which we seek to abolish. But the Biden administration did do an executive order last year that made it easier for veterans to access debt abolishment and to make sure that their credit scores were not impacted. So there have been some small but important steady steps in helping to address this sort of deep injustice.
Thank you, Eva. We appreciate that. You're right. There's definitely some opportunities there to do better, to serve our veterans that have served us. Any other comments? Joe, is that your hand? No, it's not. Anyone else want to comment on work done to serve, to provide assistance to veterans? No? Okay. I think we've already addressed some of those issues already. Next question, are hospital social workers helpful with assisting with medical debt? So Eva, it sounds like this is targeting you or Jared. So either of you perhaps, medical debt or any challenges in obtaining care. So are hospital social workers helpful with assisting with medical debt? And I know I've seen in many instances, hospital social workers complete Medicaid applications, and that's pre-COVID. I know in many hospitals now they have a department that does that, and so the social worker can do other things. But is there something specifically that you'd like to see social workers or partners at NASW do to support the needs of patients?
Well, Jared wants to make sure that they're connecting to him and also making sure that people know about financial assistance. I would just say, as I pointed out in the comment, that unfortunately, I do think social workers can make a huge difference. I think knowing their internal landscape around support as well as their external landscape around community partners is a really important thing for them to know both, and knowing how to internally navigate across sort of siloed departments. I suspect that most social workers are not talking to the billings office in a deep and impactful way, because the billing department is so overwhelmed quite often. And so in doing back and forth. So I just think that those probably are siloed, and that there's definitely opportunity there to build connection, particularly even I would extend that to population health, so that we're creating a conversation internally about the harm of medical debt, how it affects our community. Do our billing practices mirror the needs of our community? Are they trauma informed in how we talk to our community? And how are social workers then carrying themselves and delivering that information in an impactful and helpful way?
Okay. Thank you, Eva. All right. Opportunities to be paid. Okay, so what are some opportunities for a patient to get involved in larger discussions about health system changes? And I know there are a number of patient advocacy groups, but what are your recommendations on how to be as a patient? And I think we're all patients first. We all have professional careers and we work in healthcare or careers that are supporting those in healthcare. But what are some of the ways that patients can get involved in these larger discussions to make change, to be effective with health system change? I'm going to give that one. I'm going to start with Joe and then maybe Elita. Elita, I know you're ready. I see it again. Joe, did you have any, from a patient perspective, what can patients do to really be a part of these discussions to be effective change makers?
I think that, larger agencies and health systems will often have community advocacy or patient and family advisory bodies that connect to them in various ways and help inform governance and policy for those organizations. And so I think just asking about whether or not your local health system has those bodies is a useful thing. Often it will have additional kind of community engagement bodies as opportunities for participation as well. Again, at the end of the day, those sorts of spots get pretty limited pretty quickly, and so it can be frustrating to try to access, just to be real. I think that understanding what local, state, and nationwide advocacy looks like as well, and kind of figuring out how you can get involved there is another route, but again, can be limited in access.
Thank you, Joe. I appreciate that. I think we have time for one last question, and then we'll be wrapping up shortly. What are the best practices in shifting perspectives on access to quality care for underserved communities? And this is for closing.
Let me just hit that just because it feels a little bit health system directed. What I would say is that historically underserved communities are suspicious of the health system for good reason. It's because they have been systematically harmed and differentially treated by the way that our health system has been created and perpetuated. And so they're right. People are right to be suspicious of the American healthcare system. How can we counteract that? I think it's only through sustained accountability and showing commitment to doing things differently. And honestly, I don't know. I think that's a hard thing to execute on and a hard thing to do. I think having real engagement with community leaders and influential thought leaders in those communities is an important piece of it, right? How do you actually get that voice to the table? And are they truly representing their communities, right? And then are you truly taking their feedback and making process and system change as a result of the feedback that they're actually giving you? I think a big part of this is workforce related as well, particularly in the health system. When you look at your physician or care provider, do they look like you? Do they understand your cultural values and beliefs? Do they speak your language? Do they even have access to someone who can help translate and interpret your language, right? To Elita's work. And I think that those are all critical questions that are broader in scale. But I think having some intentionality in partnership with the pipeline for nurses, doctors, et cetera, to understand how you can get better representation into the system is, I think, a key piece of this as well.
Great. Thank you. Well, that closes us out. Thank you, Joe. You had the final word there. We certainly appreciate each of you providing your perspectives today. Hillary, would you like to take us to close? Thank you all.
Absolutely. And thanks so much again to our panelists and Elle-Marie for leading us through a really exciting discussion today. And we appreciate all of our attendees for their participation and engaging in our Q&A. We have one final session for our Summer Roundtable Series next Wednesday, which is called Health Literacy as Liberation and Suppression. And we hope you join us for that. And in the meantime, take care, stay involved, and we look forward to continuing this conversation through our ASTARISQ series. Take care, everyone. Thank you.
Awesome. Thank you all. Thank you very much.